So this first screencast is just going to give you a bit of an overview of what health promotion is and the background to it. And many parts of this we will expand more as the day goes on and also in tomorrow's session. So health promotion is part of public health. So public health is a much bigger, much broader discipline. And we'll talk more about that later. Health promotion is a wide range of activities and interventions, and this idea of enabling people to take control over their health, to make more health promoting decisions. So it's not just about telling people what to do. In fact, that would be considered unethical health promotion. So it's broader than health education, and we'll look at how dietetics fits into that because dietetics does a lot of health education, but it also includes service improvement and advocacy. It thinks about where people live, so it considers those wider determinants of health that we have looked at, and healthy cities is one example of that. And it doesn't equate health with health services. So it's looking at those much broader ideas rather than just what the health service does. So it includes a much wider variety of disciplines. That includes people working in the councils in environmental health, others who promote health in the community. So it's much, much broader than healthcare services. And it can be directed at individuals, families, communities, or whole populations. So all dietitians, dietetic assistants, and yourselves are going to be involved in health promotion in some way. So it really started back in 1986. You think, don't need much of a history lesson, but actually the Ottawa Charter is still considered very important in directing how health promotion has worked over the last few decades. And it had these 5 core areas of work that it said encompassed what health promotion is. So it's about building healthy public policy. So that's a lot of the politics and governments and that kind of thing. Creating supportive environments. So that's looking at that wider determinants of health again. Getting the community to work together to strengthen the community and so that they can actually promote health in how the community works. Developing personal skills, which includes the educational side, and I can never say this word, reorienting or reorientating health services to get them to not just be about treatment, but about promoting health. And in the UK, our health service tends to be greater focus on treatment over the years, unfortunately. So we've gone from the Ottawa Charter to more recently talking about HESIAD, health education, service improvement, and advocacy. So it's been regrouped. So the health education side includes the developing of personal skills and strengthening community action. The service improvement is much more broad than healthcare services. So it's about improving transport and town planning and other things that influence the environment. And the advocacy includes that idea of building healthy public policies and creative supportive environments, because that advocacy is including campaigning to get things changed, to change those areas. So we'll come back to those in a little bit more. I'm going to explain each of those in a bit more detail. So health education, planned activities that facilitate people to learn about health and how to change health behaviour, so behaviour change. So it gives people more awareness of issues. So there's lots of campaigns that Change for Life, for example, that have made people more aware of healthy diet aspects, but provides information. So go to the webpage, have a look at this. This is how you can make those changes. It motivates people and persuades them a little bit more about, well, here's some behaviour change that you can make, trying to encourage people to make something seem feasible for them to do. The criticism of health education is that it's very narrow. It focuses on providing information. And it assumes that more information or more knowledge or even more skills always leads to behaviour change, and we know that to be wrong. That isn't how it all works. It's much more complicated than that. And so I'd like you to spend a bit of time thinking. There's a task at the end of this screencast. In what ways do you, in your dietetic departments, do health education? Because it's a big part of what we do. Then we go on to the service improvement side. So this is quite important for thinking, right, well, what do we do? How can we improve that to make it more health promoting? And that might be changing something that's not working very well to make it work better in some way. It might be about making things more accessible or more acceptable to our communities. So it might be changing a face-to-face session to make it available online, or to create a webinar during COVID that made things more accessible. It might be that actually something was very much focused on white British type standard diets and wasn't acceptable to communities with different dietary needs. So we change it to make it more inclusive. So all of those things around service improvement. But it's not just about health services. It could be schools improving the food that they provide, improving the food environment, making more physical activity opportunities more appropriate for children. The changing of environments might mean influencing town planning to make sure that there's not more takeaways being made available. Social services have a lot to do with nutrition and food provision. So how are they improving that? And community development will look at more under place-based settings. But that's about empowering a community to take a little bit more control to make things more appropriate for their community. So again, thinking about, is there anything that your service is doing, improving the service that's making it better fit for purpose, more health promoting. So we can be doing advocacy as well, and that's about defending or promoting your cause, making things more accessible, so removing obstacles. That might be reducing discriminatory behaviour, for example, so you're making something more accessible. Or it might be looking at the needs of a specific at-risk population rather than just a very generic activity for a population. And it's quite interesting when you look at what the BDA does as a professional organisation. So BDA does quite a lot of advocacy work. It challenges government, so it responds to consultations, it responds to new policy, comments on those new policies, raises issues with government and with the food industry. Members of the BDA are involved in lobbying. We've got members of the BDA who are on all-party committees or will work with those all-party committees considering different policies. We've got members who comment on NICE guidance. So they can advocate at a national level, but also locally. If the council's making a change, if there's a consultation with the local council, dietitians could get in there and say, hang on a minute, think about this. How is this going to affect the health of our communities? So dietitians do this kind of work. And just to give you some examples here, in health education, so there's skills and knowledge. We might be delivering cook and eat sessions in the community to upskill people to be able to feed themselves in a more healthy way. There's a lot of work that goes on in children's centres to support good quality infant feeding, to promote breastfeeding, to teach people how to wean appropriately, to give information on healthy eating on a budget. Community development, so we'll talk more about that tomorrow, but it's about encouraging that community to take a bit of control, working with allotment groups or food cooperatives, food banks, those kinds of things, to make sure that the food provision is better, or providing people with recipe ideas on how to cook the food that is available. There's lots of educational things that we might do. Service improvement might be making that service more accessible by moving into primary care rather than expecting everyone to come to a hospital. Moving into community centres or children's centres where parents and children will already come. And working to prevent negative outcomes, be more health promoting rather than treating things. So we might work with the local councils to make more healthy eating information available, more physical activity opportunities available. So it's about changing what we do. And this advocacy, just some examples here where dietitians have been involved with information, for example, about the sugar tax or food labelling, when workplace health, trying to support the work environments to encourage them to be more health promoting, more supportive. And with schools, there's lots that you can do to advocate a healthy approach to food in schools, and town planning and nutritional labelling. So all things that you could get involved in, you could make the dietitian's voice heard. So health promotion has a lot of guiding principles. So it is holistic. It's looking at people, whole populations, not disease focused. So rather than focusing on a specific disease, we might do something in that. It's more likely we're going to focus on the healthy behaviours. It should very much be equitable. So this is the ethics again, working on the causes of ill health beyond the control of the individuals. It should be multi-strategy. So quite often we will be working, I'll come back to it a bit later, we might be working with an individual, but we'll also be working with communities and populations. And it's aiming for people to be involved, supporting people to be empowered, to be able to make their own decisions, to help themselves as much as possible, rather than doing things for them. And it's not just health and social care. It's your local authorities, it's your local communities. So it's much, much broader than health care as such. Another thing that it would say is it's enabling. So we will work in partnership. So we might be not just be working with dietitians, but we might be working with local food producers or local schools or local environmental health officers. So you're looking at a much broader perspective than just dietetic services and dietetic professionals doing something for their patient group. So it's much broader. So we look at what the needs of people are to try and work with that group of people in partnership with networks and look at resources, developing knowledge and skills. And we're also aiming for something that's sustainable. So it's not about kind of helicoptering in and going and doing something to a community for 6 weeks and then disappearing. How can you help that activity to be sustainable? How can you help that community to take more control for themselves rather than just having that short-term impact? So what I'd like you to do now, which we will then come back and discuss, is think about what you know that your dietetic department is involved in, that you think is a health promotion task, and decide whether you think it's education, service improvement, or advocacy. It's more likely to be health education, and it's just a good example here with cardiac rehab talks. For any of you working in hospital, the likelihood is that your department will be working and delivering cardiac rehabilitation talks on a regular basis. It's a very common thing to do. So that's health education. That's about educating people on a healthy diet when you've had a cardiac event. So have a think through of what you know about that's already going on and where it fits in that continuum. And I'm going to give you a few minutes to talk about that, and then we'll come back and have some discussion as a group.